Well, good afternoon or good morning, everybody, and welcome to our webcast today on learning from patient narratives through innovative feedback reporting methods. My name is Dale Schaller, and I'll be moderating our session today, which is presented by the Agency for Healthcare Research and Qualities, or AHRQs, CAHPS user network. Next slide, please. Just a few quick housekeeping details to address before we get started. With respect to audio issues, if you have any trouble, you can always basically use your phone to call in by finding the dial-in number and the meeting ID and call in that way with your phone, or you can select Call Me and enter your phone number and receive a call back from Zoom. If you have any sort of connection issues, you can always try to log out and log back in to unfreeze your screen. And most importantly, we welcome your questions for the webcast today. You can use the Q&A icon to submit a question. We ask you to add your name and organization if you feel so inclined, so we know a little bit about where you're coming from. And please also note that the raise hand and the chat features that normally are available on Zoom are not available for today's webcast. Finally, we have an event website, which was included in your registration confirmation, which will allow you to download the presentation slides we're using today, view the agenda, and also look at more detailed information about our speakers today. That event site is located at this URL, events.westat.com/CAHPS for CAHPS. And that should be available online until about the end of next week. Next slide, please. So we have a very exciting, we think, and full agenda for you today, starting with a brief welcome from AHRQ. We'll then have a kind of an overview of the New York-Presbyterian Patient Narrative Reporting Project, which forms the basis of the study setting for the innovative feedback reporting method that we'll be describing, both in terms of its impact on staff experience as well as patient experience. And then we'll hear directly from NYP leadership about the organizational impact of the project. And of course, we'll try to leave as much time as possible for your questions and answers at the end of the presentations. Next slide, please. We have a really great panel of speakers today, and they're all sort of turning on their cameras now. Starting with Caren Ginsberg, who directs the CAHPS and SOPS, that's SOPS, stands for Survey of Patient Safety Culture Program at the Agency for Healthcare Research and Quality. Joining Caren on the panel and in the gallery is Ingrid Nembhard, Professor of Healthcare Management at the Wharton School at the University of Pennsylvania, and Mark Schlesinger, Professor of Health Policy at the Yale School of Public Health. And we're also very pleased to welcome our field partner, Rick Evans, who is Senior Vice President of Patient Services and Chief Experience Officer at New York-Presbyterian Hospital. And again, I'm Dale Schaller, a member of the CAHPS team, serving today as both your moderator and a panelist. So with that, it's off to you, Caren.
Thanks so much, Dale, and welcome everyone to this webcast today to update you on AHRQ's work on the patient narrative questions that accompany CAHPS surveys. I'm so happy you could join us today. I noticed from your registration information that many of you are new to CAHPS and the patient narrative work. So I'd like to just start off today's presentation by giving you a little background on my agency and the CAHPS program, just to help provide some context for the discussion today. Next slide, please. At AHRQ, we talk about our core competencies, so I just want to review that for a minute. AHRQ is a research and development agency of the U.S. Department of Health and Human Services. And as a research and development agency, we fund research and evidence that makes healthcare safer and improves healthcare quality. We create tools for healthcare professionals to use to improve care for their patients. Then we generate measures and data that you can use for quality improvement or to help you help track performance and evaluate the progress of the U.S. healthcare system. Next slide, please. So CAHPS stands for Consumer Assessment of Healthcare Providers and Systems, and this program has been funded continuously by AHRQ since 1995. So we're 28 years old now. And we are a program that focuses very broadly on patient experience of care. The CAHPS surveys are one component of it. The CAHPS Patient Experience of Care program conducts research to advance the tools and methods for measuring patient experience of care. And I'm going to define patient experience of care in a minute. We conduct research to advance strategies for reporting patient experience measures, methods for improving quality based on CAHPS survey results. And I just want to mention here that we don't mandate the use of any of our tools. We're not a regulatory agency, we're a research and development agency. And so if you have requirements to conduct or CAHPS surveys to meet programmatic goals, those requirements come from other agencies, not ours. And you might have heard about some of the databases that we maintain for selected CAHPS surveys. Those databases are all for participation is all voluntary, and the purpose is to help you understand your CAHPS data and help you improve quality in your organization. The next slide, please. So I want to talk about what we mean when we say patient experience of care. Patient experience is an objective measure of what actually happened to the patient in the care encounter, or how often something happened. And it's a very different measure than patient satisfaction. And the two are often used interchangeably, but they're very different. And patient satisfaction refers to how patients feel about their care, and their feelings about their care, as we know from research, is rooted in what they expected their care encounter to be like. So it doesn't reflect what actually happened or how often it happened, just patient satisfaction refers to how patients feel about their care. So some of the CAHPS measures include communication with providers, access to care and information, care coordination, but these are just some examples. They encompass the range of interactions that patients have with the healthcare system. And I want to point out that CAHPS surveys can be customized with supplemental items. On the next slide, please. What we're going to talk about today are the supplemental items that are ask patients in their own words to tell a story about their care. These are the narrative supplemental items. The narrative items complement the core set of closed-ended CAHPS survey questions, and they provide value-added information that's helpful to all of us, patients, consumers, clinicians, and staff. And I want to point out that the narrative items, as are all of the tools that the CAHPS program develops, they are developed and tested with an established methodology to ensure scientific rigor. So with that, again, welcome everyone, and I'm going to turn this back to Dale.
Thank you, Caren. I am going to now just present a brief overview of, can we go back to the title slide, please? Of what we call the Patient Narrative Reporting Project that we undertook in collaboration with our partners at New York-Presbyterian. And now the next slide, just briefly want to acknowledge that there are other members of the research team that worked on this for over almost 5 years. From NYP, members of the patient experience team that worked directly with Rick, and members of the CAHPS team that work with Ingrid, Mark, and myself listed here, all with funding support from the Agency for Healthcare Research and Quality. Next slide, please. Just to give you a little bit of background on why we focused on this project is, as Caren said, patient narratives can provide valuable insights for improving patient experience in ways that complement the kind of information we get from closed-ended survey questions on CAHPS and other patient experience surveys. The CAHPS team over the last 5 years has developed a narrative item set, or NIS, for ambulatory patient experience surveys, including the CG CAHPS survey. And we have learned a whole lot about how to collect information, robust information, rich information from narratives directly from patients. What we have also learned is that practice leaders and staff and clinicians face pretty steep challenges sometimes in learning from and using these patient narratives to actually affect change. And so what we've concluded is that optimal learning requires some kind of structured support that facilitates the access to those comments, their interpretation, and their use, which is why we have moved on, next slide, to develop and test a way of doing that, which we call a reporting interface that we worked on in conjunction with New York-Presbyterian It's an innovative method of reporting patient narratives, in this case, collected with the narrative item set developed for the CAHPS clinician and group survey. Our aim was to examine the impact in a study setting, experimental setting, on both the experiences of medical practice staff and clinicians, as well as on the experiences of patients themselves. Next slide. The study setting within New York-Presbyterian is what's called the Ambulatory Care Network, or ACN, which consists of 22 primary care and specialty practices distributed throughout the borough of Manhattan in 2 major campus areas, one with respect to Weill Cornell, and the other affiliated with Columbia University on the east and west side, respectively, of Manhattan. Next slide, please. The design that we used to conduct this study was a sort of comparison of intervention and control sites. We divided the 22 ACN practices into 12 intervention sites and 10 control sites. They all received over the period of the study the same modified CAHPS survey with this narrative item set attached, but the difference was within the intervention sites, they received this new narrative reporting interface with active user support, whereas the control sites received the standard way that NYP conducted its feedback reporting of patient comments. We collected 3 sets of data to assess the impact of this intervention. One is qualitative interviews with practice leaders, and then 2 forms of quantitative data, one from a staff survey that was conducted of practice staff and clinicians, and the second was the modified CAHPS survey itself, assessing patient experiences. Both of those data sets we'll be talking about further in terms of what we learned through the evaluation. Next slide. To give you a sense of how NYP had traditionally reported comments back as they collected them through the ACN practices, basically consisted of a weekly distribution of essentially a spreadsheet. You can sort of see a sort of a screenshot of what that looked like. It was basically what was the name of the site, the verbatim comment listed in rows with the date of the visit and the specialty of the practice. And so it was basically a listing of all the comments by site, by date, without any sort of interpretation or analysis. Next slide, please. What we developed was based on a careful review of what we were learning through our focus groups with the NYP practices in terms of what kind of information would be better for them to receive this information, what kind of sort of reporting interface. And so we developed a prototype based on user needs identified through the series of focus groups that we conducted with the ACN practices. We partnered with a design firm in Minneapolis called Wowza. They brought us through what we called a design sprint, which was a really rapid, fast, and efficient way of developing a prototype of this interface that we shared with the ACN leadership, and then with their feedback modified again for testing directly with users. Next slide, please. Now, the next few slides, I'm just going to show you a few selected screenshots of what this interface actually looked like. This is a website that practice leaders were able to log on to through simple credentials. They get to a landing page or a dashboard page, which shows the practice site for a period of time. In this case, it's sort of January through July, what the distribution of comments were in terms of their valence, positive in green, negative in red, and the neutral comments sort of in between in a gray. It also listed over this period of time the number of themes that were pulled from the comments through qualitative coding that were both positive as well as negative. And at the bottom of the screen, you can see sort of a trend line that shows by month the distribution of positive and negative comments. So users could have sort of a historical look at the trend line of comments in terms of their valence. Scrolling further down on this page, we also did was we integrated the distribution of comments according to their relationship to the actual composites of the CAHPS survey, office staff, access, care coordination, and provider communication. Was a really important feature for the NYP leadership to be able to integrate information from the narratives themselves with the actual CAHPS scores, so you could sort of see the interrelationship between the two. Next slide. This slide gets you into more detail, and it's a lot going on. It's actually sort of a combination of different elements of the interface, but it basically allows you to choose a month, and then you can select a date within the month. You can see sort of this first top line sort of trend line that shows you green and red, and you can actually pinpoint comments by day, so you can see what's going on positively or negatively and think back to what was going on in your practice. On the left side, there was a legend that allows you to filter by visit type, because we classified information not only by in-person, but by telehealth visits, which NYP instituted shortly after the pandemic, by thematic sort of descriptor, from sort of access to communication to other elements of key themes that we extracted from the comments, to key actors and even key patient attributes. So for any given theme selected, or attribute or actor, the user is able to actually look at specific comments related to those areas. And the other piece of this sort of detailed page that sort of shows you a little bit of a pull-out box, which is the narrative in full. That is, when a respondent answers the 5 questions in our narrative item set, we actually are allowing the user to look at the full extent of the comment, so you can see the full picture, not just the particular comment related to the theme that was filtered out. Lastly, on this page, circled big on the right takes you to another page, which is really the answer to the first question in the narrative item set, which is, what are you looking for in a practice? Sort of a sense of expectation, which we found to be a very valuable piece of information for the practices, because they were not only able to look at experiences as reported by patients, but also what are patients actually looking for, so that practices can kind of gear up to address those patient needs. Next slide. The last piece of the narrative interface was what we call the action report. So as a user progresses through this site, they're able to select comments that they found particularly interesting and helpful that they might take and use later on in huddles or meetings with staff clinicians. So they were able to basically view selected comments and then be able to print or save in a PDF, sort of a hard copy of this for distribution within those subsequent meetings. Next slide, please. We mentioned active user support. So it wasn't just a website. We actually also had active user support with respect to the patient experience lead within the ACN meeting every month with the intervention sites to do demos, to sort of review how to use the action reports, to update the interface with new coded comments, and even to use sort of demonstration videos as they send out email updates about how to use the site. Final slide before I turn it over to Ingrid is what we learned in doing the qualitative interviews with 20 practice leaders and supervisors drawn from both the intervention and control sites. And basically we found that everybody basically loved it. Found it to be very friendly, visually pleasing, very easy to use, facilitating the use of narratives, able to sort of look at complex sets of data with clear visualizations, the graphics, the color coding, et cetera. The detailed narrative that allows you to drill down and look at the individual comments from individual patients was highly valued. And the other thing that we learned, which is really important as you think about the findings that we're going to present, is that most of the use of this particular tool was focused on staff performance as revealed through narrative comments and the scores, as opposed to clinician performance. And the only real downside we heard was our ability to update the site only every month, as opposed to more frequently refreshing the site with more frequent recent comments. So with that, I'm going to turn it over to Ingrid to talk about sort of our first wave of quantitative data that allowed us to evaluate the impact of this narrative feedback reporting interface. Ingrid.
Thank you, Dale. So as Dale said, our interviews gave us insight into what staff experienced while using the interface. For us, it was important to understand as fully as possible how our intervention changed the experience of caring for patients for all staff who could have been affected by our intervention. So with our NYP colleagues' administrative support, all staff working in the 22 NYP practices were invited to participate in a survey. Next slide. You can see here the flyer that we use to advertise and invite staff to participate in the survey. We had 333 staff, about 81% of staff in those 22 practices complete the survey. What was nice about that is they reflected the various professional roles in the practices, with the largest group of respondents being physicians or physician assistants. 43% of respondents were actually clinicians. Conversely, if you think about it, the opposite means that over 50% of our respondents served in other critical administrative support roles for the practices. As researchers, we were really pleased that so many staff participated and the diversity of roles that they held. And I think one of the first things we found was that by simply administering the survey, was that staff welcomed the opportunity to share their experiences with patient feedback. Many had never been asked about this subject and wanted to share how patient feedback had affected them. Next slide, please. The survey data allowed us to answer at least 4 key questions related to staff experience. The first is, what do staff learn about patient narratives? The second, are behavior changes linked with seeing patient narratives? Third, are there significant differences between intervention and control sites in what is learned and behavior changes that result? And finally, is there an association between staff seeing patient narratives and feeling more or less burned out and understood? We all know that the workforce burnout and well-being are significant issues in healthcare today. It's possible that stories from patients about their experiences exacerbate staff feelings of being misunderstood or burned out, or it could be the case that it leaves staff feeling more appreciated, which lessens feelings of strain. And so our survey data allows us to examine this possible link, which we think is actually an important one to understand. But first, let me share with you answers to the first 3 important questions. Next slide, please. So with respect to our first question of what staff learned from narratives, we found that staff had multiple learnings from patient narratives that can facilitate improvement. In the survey, we asked staff to reflect on the last 6 months and tell us how often written comments from patients about their care had been useful for identifying each of the 8 types of learnings that you see listed here. Each of these can facilitate improvement efforts, and I'm not going to read them all. Let me just say that some of them, such as learning about best practices used by clinicians and staff, are positive things to reinforce and spread. Others, such as learnings about problems with the practice's day-to-day operations, are things to rectify. And still others, such as learning about exceptional people or ways to do things, are extremely positive examples that you would want to elevate. Click these. In looking at the data about staff learning in these categories, we see that at least 1/3 of respondents felt that they had learnings from patient narratives in each of these 8 categories. Staff learned about the positive, the negative, and the exceptional, and with the highest categories of learning being about practice operations that work really well and about exceptional people. Next slide, please. Notably, many respondents reported having several categories of learning at least frequently. 41% reported experiencing at least 4 of the 8 learning options. So we take that as the first answer to the first question, is that staff can learn in multiple ways from patient narratives. Now, if you take that as given, the natural question to ask then is whether they change behavior in response to these learnings. Next slide, please. The answer to that second question is also yes. In the survey, staff were asked to share how frequently they personally made 2 changes after seeing narratives: changes in their own behavior and changes in their own communication patterns. They were also asked to report if they had observed changes in practice operations and patient care due to patient narratives. You can see in this figure that about 35% of respondents who saw narratives had frequently or very frequently made changes, and about 30% observed clinic level changes due to narratives as well. These percentages combine staff and practices with the intervention and those without. And recall, though, that we want to know whether the reporting intervention made a significant difference in staff experience with narratives. So we're seeing the pool of information now. Next slide, please. When we examine that by comparing whether reported learning and changes differ significantly between staff and practices that had the intervention and staff and practices without it, you see here that staff and intervention sites reported higher frequency of learning across categories. So that's the red bars. Before we even adjust for staff characteristics like their role, their tenure, their frequency of seeing narratives. Next slide, please. The same pattern holds true when we look at staff-reported behavior changes. So again, here looking at the red, we see that staff in intervention sites reported more behavior changes than staff in control sites. Next slide, please. When we statistically adjusted for staff characteristics, so again, their role, their tenure, their frequency of exchange, the mix of positive and negative comments they saw, we found that intervention sites had significantly greater behavior changes and learning than control sites. You can see the magnitude of the intervention effects in this figure. You can see that they get to be pretty large. The most pronounced differences between intervention and control sites were evident for narratives that conveyed positive experiences. So those are the ones in the green, things like identifying best practices. The smallest were for those calling out exceptional experiences, with the narratives that identify weaknesses or opportunities for improvement associated with intermediate differences between the intervention and control group. The only non-significant difference was for learning about exceptional ways to do things. Next slide, please. We also found additional effects that simply make sense. So, for example, learning effects tend to be greater for those who had more narrative exposure. They had less years of work experience, so they had more opportunity to learn and perhaps were more ready to do so. Those that held non-clinical roles, they had greater learning experiences, and those who had more exposure to positive narratives. And we know from psychological research that people tend to be more receptive to positive feedback, so that is not surprising. Next slide, please. Our final question, as you will recall, was about the nature of the link between seeing patient narratives and staff well-being, and we thought this was important. To answer this question, we examined how much staff experienced two forms of feedback through narratives and how that related to burnout. The first form is positivity. So the more complementary the narratives, the more positive the feedback we'd say through those narratives. In our review of the thousands of narratives received by the practices that we studied, the mood was about 60% positive. Consistent with that, when you looked at our survey data from respondents, about 37.6% of survey respondents reported that at least 70% of the narratives they saw were positive. So again, we're seeing that narratives really can contain a lot of positivity within them. The second form of reinforcing feedback was empathy. And we see this in narratives that convey an understanding of the challenges that staff face, and in those that convey appreciation for staff effort. In our survey data, 31% perceived one of these forms of empathy in the narratives that they saw, and another 12% perceived both forms. So that's about 42% of staff that sensed empathy in the narratives that they saw. Next slide, please. When we compared these percentages to burnout, we saw a really striking pattern. Reported burnout declined with the level of reinforcing feedback received through narratives. So as you move along here from staff seeing no comments to seeing any comments, to seeing a more positive mix of comments, to experiencing some form of empathy, to experiencing both positive mix and empathy through narratives, we see the reported burnout declines and quite a bit, going from about 42% to 8%. Next slide, please. The differences between groups is significant, even when we adjust for other characteristics of survey respondents like role and tenure and intervention site status. What that implies is that we should not forget to share narratives that convey positivity and empathy with our staff and our clinicians. They may well be a significant tool in the fight against burnout. All in all, I think our intervention is showing that they are able to facilitate the use of patient narratives that have positive effects for staff. Of course, it matters the effects for patients too. So let me pass now to Mark to share our findings with respect to patient experiences. Mark?
Thank you, Ingrid, and thank you, Dale. It is my great pleasure to join you all for this third leg in our relay race evaluation of the NYP intervention. Next slide, please. In this third stage, what we're going to do is move through things in 3 steps. You can see a theme developing here. First, we're going to go back to the staff experience surveys to get a better sense of who was seeing patient narratives with what frequency. Second, we're going to introduce to you our statistical models for evaluating the impact of that narrative exposure and show you the results across 4 different domains of patient experience. And then finally, we're going to conclude by drawing some inferences from the pattern of results we see about how narratives have impact, how people learn, and how that learning impact diffuses over time. Next slide, please. Click one more time, please. So, when we go back to the staff survey and look at the distribution of who actually sees patient narratives, what we see on the left with the gold bars are that it turns out clinicians are the ones who report most frequently seeing at least some narratives. But if you look at the people who see narratives frequently, as shown by the orange bars on the right-hand side, what you see is that clinicians get brief and shallow periodic exposure to narratives. But in fact, the groups that see narratives most frequently, and notice the scale is different on the bottom of both graphs, but the people who see the comments most frequently were supervisors, administrators, and non-clinical staff. 1 in 6 of the clinicians who saw some comments saw comments frequently. About 2/3 of the administrative and non-clinical staff who saw comments saw them frequently. So that leads us to believe that there are going to be some hypotheses that will lead to differential impact, playing off some of the results that Dale reported earlier from the intensive interviews. Next slide, please. In fact, when we explored more carefully through those intensive interviews, what we found was that practice administrators were the primary agents for making use of the narrative interface. Medical directors at the intervention sites were sometimes engaged, but sometimes not. And that led to individual clinicians having this kind of more shallow and sporadic engagement. Consequently, the administrators leveraged the impact of the narratives coming in largely by the people who worked with and for them that would be most responsive to their influences, which were largely the administrative staff. So that led us early on to the hypothesis we were likely to see a kind of differential impact of the narrative feedback on patient experience. How did we assess that? Next slide, please. So what we did was look at all 4 of the domains in the standard CAHPS CG survey: access measures, office staff performance, provider communication, and care coordination. We looked at almost 10,000 patient surveys that came in. We have a year of data before the intervention began, and we used that to norm the pre versus post, or the intervention versus the non-intervention sites. And then we had 9 months of additional data once the intervention began. So the statistical models that we estimated were what are called difference in difference models. That is, we took the intervention and the control sites, recognizing they started at somewhat different places, and we looked at the change that occurred once the intervention occurred at both places. So what we're going to report are the relative differences that happen in the intervention site versus the control sites, controlling for a dozen different patient level characteristics, which you see listed here at the bottom. Wait, good, thank you. And another 6 different characteristics of the sites. Okay, now time for the next slide. So this is what we found. So we have a total of 18 different models that are being reported. 14 different individual response questions, and 4 different composites. The composites are in each of the 4 domains reported on the left-hand side. What we're illustrating in this particular slide are the coefficients on the intervention site designator as a proportion of the mean outcome that was being reported on the patient surveys. So all the bars that are above the horizontal line show positive intervention effects relative to the control sites. Dark green are statistically significant, light green are not significant. All the bars that are below the horizontal line show negative effects of the intervention site. Dark red statistically significant, light red not statistically significant. Next slide, please. So if we look across the four different, back one, please. Thank you. So if we look across the four different domains, you see strikingly different results. For access and office staff, all the intervention effects are positive. 5 of the 8 are statistically significant. If you go all the way over to the right and look at coordination of care, all the intervention effects are positive. Now, those are all light green, but there's a caveat there, because the way the CAHPS survey asks coordination of care questions, they're screening questions that come first. And so the sample size on the coordination of care results is about half the size as for the access or office staff results. We estimate that if the sample size were equal across those 3 domains, at least 2 and possibly 3 of the coordination of care results would have been statistically significant. So it looks like we're getting positive increases on the order of 5 to 10 percentage point increases in mean performance across 2, maybe 3 different domains, but not provider communication, as is quite evident from these results. And so the question is, why is that the case? Next slide, please. So here's what we know for trying to make some interpretations. We saw in the results that Ingrid presented dramatic impact on staff learning and behavior changes that result from staff learning, as well as quite significant impact for certain kinds of narrative content on reported levels of staff well-being. Those things tend to translate into these 3 different domains of positive results for access, office staff performance, or coordination of care. But remember that the narratives are being implemented by way of the discretion of the practice administrators, who are focusing in the domains where they have the most influence. That is not provider communication. So it is not surprising that provider communication didn't show the same positive results. But it was a little surprising to us that we actually had a couple of negative results. And so we have a tentative hypothesis about that, which is that partly what is going on is that the ACN, being part of NYP, is a clinician training site. So new clinicians are being rotated in for their training at particularly the large primary care practices in the ACN. We believe that as the administrators were more focused with narrative feedback in the other 3 domains, that made them a little less attentive to the rotating in of the new clinicians, and perhaps they were not being reinforced enough in terms of good practices of patient interaction. That's consistent with the narrative content. Remember, we saw and coded all 10,000 of the narratives associated with that, and it looked like the negative feedback at the intervention sites was largely associated with the newly rotating clinicians who were coming in. So that brings us to the bottom line, as with all our research projects, which are, where do we want to go for future research? Remember, we're evaluating the intervention here for only about 9 months, a very short-term intervention. It would be great to know what happens over the longer term. We're evaluating at one site, New York-Presbyterian. It would be great to know how it would work in other kinds of sites, other sites that were not academic medical centers, rotating in new staff, other sites that had not been as profoundly shaped by the pandemic in its early year as was the New York City area. So there are lots of important questions still to be explored. We believe that the results that we have so far from this evaluation are exciting enough and constructive enough that it merits investment in these additional research inquiries. And with that, I'm going to turn things over to Rick for the New York Presbyterian perspective.
Thank you, Mark. And it's so nice to be with all of you. And I want to share my gratitude on behalf of New York Presbyterian to AHRQ, to Dale and Mark and Ingrid and the team that worked with us. This has been a really positive and remarkable journey for us. We've learned a great deal from it. And we're also hoping that our experience helps all of you who might be listening out there and want to explore these things. So I'm really happy to be with everyone here today. Next slide, please. I'm just going to give you a very high-level overview of how this how do we see this from the New York Presbyterian perspective. First, in terms of using narratives in general, it's very clear to us in our experience, not only with this project but with others, that narratives add richer color to the score data. You know, I'm struck again and again about the power of storytelling in terms of getting people to engage, getting people to learn, and sometimes even change the way they do things. And this, in my view, is just another way of telling a story, hearing a story, understanding a story. And it certainly is an amazing complement to the scores that we get on our surveys. It's also very compelling and motivating for providers and our team members. We find that you know, sometimes a number on a spreadsheet doesn't have the same impact as an actual story of something that actually happened, particularly if people are named in those comments, particularly when they're named positively. Really, really compelling, and people engage with narratives. It helps us sharpen our themes for intervention. I would consider narrative data to be modifier data to what we might be seeing in actual scores on questions. And there are times when it not only helps us clarify our themes, but provides additional themes, additional things that wouldn't show up otherwise in our feedback from our patients. So narratives, I think, are powerful. And it's clear at New York Presbyterian and from my perspective that really the future of patient experience data, I think, is in narratives and in unstructured data. When you look at what's happening with AI, I'll talk more about that in a minute. It's really more and more where we're getting a deeper understanding of what our patients and their families really need and expect from us. The next slide, please. In terms of its organizational impact on NYP, this project, the fact that we were doing it with this group, which our organization sees as a real honor to be asked to do this, it clearly elevated narratives within our organization, not just within our ambulatory care network, but outside of it. It really helped us engage our teams deeper in patient experience work and buy-in, particularly in our clinicians. This really was a draw for them. It helped, I think, all of our staff, even our patient experience team, be engaged in a deeper level. And you saw some of that in the data that's been shared by my colleagues in terms of understanding patient feedback, understanding not only what the content of that feedback is, but the value of that feedback in terms of what we're trying to accomplish for our patients and families. And then this has been one piece of, and I kind of alluded to it in my last slide, of really an expanded focus at New York Presbyterian on narrative and unstructured data. We're increasingly using AI to help us understand narratives and comments and letters. And it's amazing how that's adding to our work, both our understanding of what we need to be doing to improve the patient experience. And again, as I said above, and in terms of engaging people in that improvement work. And the next slide, please. from a well-being perspective, I'll start with the bottom bullet here because it was just mentioned. New York City, in many ways, had COVID first and worst, and it was an extremely scary time for all of us who were here during that time period. And I think one of the things that, COVID has done this in many respects. A lot of the issues or problems that were within healthcare, COVID shined a spotlight on them, and actually, in some cases, made them more acute. One of those is the problem of burnout. And I think through this work that we've done, these narratives, working with narratives, understanding and engaging with them, helped connect our team back to purpose. Because it's really patient voice in a very real sense. It's very, these narratives are very good for recognizing our staff. And I think this was mentioned earlier, particularly when you can say things positively, when you can highlight empathy, when you can highlight excellence. That's a motivator for our staff. It's a motivator for any of us, if you think about that. It personalizes patient experience improvement work. Again, when all you're looking at it with PX, and trust me, data is critical, particularly for our clinicians. But if all you're looking at is spreadsheets and scores, you can really lose sight of that. Every score is a group of patients giving us feedback. The narratives remind us of that this is the cumulative feedback of the people that we're trying to do our best to serve. And I already mentioned COVID, so I think it's actually helped us recover. Process that's still underway, but really helped us recover. Particularly in the ambulatory care setting where we use these narratives and worked on this project. I will stop there. Again, it's my pleasure to be with you, and it's been an honor to be part of this project.
Thank you, Rick, and thank you, Mark and Ingrid. And Caren, let me invite all of the panelists to turn their camera back on so that we can field some of the questions that have come in. We have about 15 minutes to do that. I'm going to actually start with, thank you. Remember that the Q&A icon in Zoom sort of screen at the bottom of your view allows you to enter the question. I think you'll all understand that. So I want to go back to kind of where we started with the webcast. And Mark, there's a question that I'm going to field to you with respect to the platform that were used for coding the comments as you sort of reported them.
Yes, so the narrative item set, as Dale described earlier, was developed first before we took it to the New York-Presbyterian framework. And we had developed this very sophisticated research-oriented coding scheme that had like 500 categories in it. And it was big, it was cumbersome, it was super useful for research. But moving it back to the feedback and quality improvement space meant we focused it down on a narrower set of themes and a smaller set of categories that included, roughly speaking, about 100 distinct codes in them, and which could be coded reasonably quickly. We were coding roughly on the order of 500 narratives with a single coder in about 2 or 3 days worth of time. So it was a relatively efficient, focused version of that bigger coding scheme we used for research.
That's great. So there's a couple other questions related to the collection of the data. One I'm going to ask you, Rick, was how were the surveys actually provided to patients? Was a third party like Press Ganey used, or was it directly through AHRQ? Just talk about the survey administration briefly.
Sure. So we use the CAHPS survey. We administer that through Press Ganey. And obviously we use the narrative set that is being referenced in this project as part of that survey. So it was done by our vendor on our behalf.
Just a quick follow-up on that too. Does NYP use any sort of interventions to promote patient participation or their engagement in completing the CAHPS survey?
Well, we don't offer any incentives for survey completion, no.
All right. Another question, Mark, this is for you in terms of survey administration. Was it all done in English or were there other languages used? I think you can address
Yeah,
that.
the simple answer to that is it was done in English and in Spanish. And what was important from the early stages of the narrative data collection to the later stages is that New York-Presbyterian switched to electronic survey administration, which allowed us to get much faster feedback of the comments when they come in and got coded. The ACN staff would wish it to have been even faster than we could do it, but we were basically turning things around within about a 1 month time.
Right. So again, with respect to coding and just sort of the impact of COVID that Rick was describing, what was the impact of COVID? Did you detect anything with respect to the intervention and the timing of the intervention? I'll send that to you, back to you, Mark.
Yeah, it was quite profound in that in the early days of the pandemic, and you have to recognize how different New York City was than many parts of the country during those early months of the pandemic. We saw really an amazing outpouring from patients of what we called grace for providers, of real admiration and willingness of the patients to say, we know everyone's struggling with the pandemic, but we are just immensely grateful to the providers and the staff for their ability to keep things functioning in these incredibly difficult circumstances. And that deep shot of empathy that came from those early months of pandemic experience carried over to a very great degree, even as things began to get normalized, even as things moved back to more of a standard operating procedure. People didn't forget the gratitude that they had for providers, both clinical and non-clinical, during those early months.
Okay.
Maybe let me add that in terms of how we incorporated that into the analysis, we actually had a variable that captured the mix of positive and quote unquote negative comments. So we plug that in, and the beauty of that is not just controlling for its COVID time, but also the mix, which is what we really wanted to get to, that positivity that Rick spoke about, that I spoke about. We had a variable in our analysis to capture that when we were talking about well-being effects.
I wanted to build on, thank you for jumping in, Ingrid. There's a question from Mariah Maggio, which could either, maybe both you, Ingrid, and Rick can sort of contemplate. She says, we struggle with supporting clinicians and administrators and staff to embrace the value of narratives, especially when the narratives contradict the quantitative scores. Are there any insights from the focus groups or even our study findings that might give some insight in how to sort of reconcile the contradiction between these two measures? And Rick, did you want to sort of think about that?
Yeah, because I get asked that question a lot. And what I talk about is comments as modifiers of data. And there are times where a patient will be answering a question, right? And they answer that question, but then often narratives become something that's more summative, if you will. And so I think other factors can flow into that. So they don't always match per se, but they are both sources of feedback that we need to read and understand and balance. And as I said, more often than not, at least in my experience, the comments help us understand a score a little more deeply, whether that's what the feedback really means with regard to a score on a survey, or in some cases how it differs from what we think it means. That makes sense.
It does.
Right. Dale, can I add one additional thing to this? And this is a finding that is not just from this particular intervention or this particular setting, but it adheres in all of the narrative research that's been done on patient experience, which is that very often patients who will do things like provide a top box score for provider communication or for access to care will nonetheless see something that didn't work on one given visit or in one particular interaction. And it's precisely because they are so positively inclined to the practice or to the particular provider that they'll say, something was wrong on this particular visit, and they will use that to highlight particular circumstances that give you actionable feedback about how to respond. They're not just complaining about everything, they're calling out something in particular that's worthy of change.
Right. So I want to just try to get a couple more questions here before our time is up. There's two that sort of relate to each other. One is asking specifically if there were differences that we saw in terms of patient feedback between different population segments, specifically any notable feedback from Medicaid patients. And either Mark or Ingrid on this one. The related issue is, again, sort of results by product type, Medicaid versus commercial versus Medicare. I don't think we analyzed it by payer, but any differences that we discovered with respect to patient attributes by insurance coverage. Mark, do you want to start with that?
Yeah, I'm happy to, but Ingrid, do you want to, anything you want to throw in first before I go on? I've been talking a lot.
Go ahead, since I was on mute.
Okay. So yes, we saw several notable patterns. Pattern number one is that patients who were on Medicaid feared that they would be treated not as well as people with other kinds of insurance. It turns out that there were not significant differences across the scores that were coming in, but they were guarded, they were worried, they were concerned about treatment. And so they approached the medical experience in a somewhat different way, a more cautious way. Second, even though the survey was being administered in Spanish as well as in English, it was very clear that the Spanish-speaking respondents were feeling less empowered in their interactions when they were on site. But that often meant that it was more important for them to use the feedback mechanism to say what wasn't working for them. And that was powerful. And in fact, what we heard back from the clinicians when we did the staff survey was they wished that we had more respondents who were the Spanish only speaking respondents, because they felt that was the group they needed more feedback from.
And
Okay.
they also wanted feedback from Medicaid population.
Yep.
We certainly heard that when we administered that. We also, in terms of, or just to make clear that we sort of did account for payer mix. When we looked at the patient experience scores, one of the practice level variables that we included was payer mix, percent of patients with Medicare, percent of patients with Medicaid, because we know that that can matter and that we need to adjust for that kind of information as well.
So I have a couple of kind of forward-looking questions, Ingrid, I'm going to toss to you. They're related in the sense of what are plans, if we have any, in terms of moving forward to expand this work with narratives to other sort of settings, whether it be acute inpatient or skilled nursing care. And the related question is, basically, how might this sort of strategy be taken forward in other sort of settings and contexts?
Sure. So Mark gave a list of things that we hope to do in the next phase. And in fact, we are continuing to do this kind of work and this kind of research. So we're now moving in a project to the inpatient hospital setting, collecting narratives in that setting and understanding how they can be used to improve the patient experience in that setting. We're giving particular attention to understanding the emotional experience of patient care and some of the new work, and allowing narratives to allow us to learn a little bit more about that and how that can relate to CAHPS scores. We're exploring, as Rick said, I think there is health systems are excited about the use of narratives. The question becomes how to process the data. And so there's a big push to understand the role of AI and other natural language processing. And there's research that is being funded by AHRQ now to help understand those elements and how we move forward in that regard. And so we too will be considering and looking at that as a way to push this work forward, with the idea being that these really are complements. The survey scores and the narratives are complements, and what we want to be able to do is leverage both of them and get better at doing it more quickly. And so what is it that we need to do to take the full richness that is there and move it forward?
I think that's a great sort of forward comment to wrap up with. Let me just ask you to move forward in the next slide. To receive periodic updates, we ask you to sort of sign up for a listserv that sends you email updates on all aspects of the CAHPS program. You do that by going to the AHRQ site and finding the email update sort of up in the upper right-hand corner, and then you can select exactly what you want to receive with respect to the CAHPS program. Next slide, please. So we didn't get to everybody's question. We got to a lot of them, but if you ever have any other questions or comments or insights or information you'd like to share with us, there's 3 ways to do it. You can send us an email at CAHPS1@WESTAT.com. Our toll-free number is 1-800-492-9261. And of course, our website, which is full of information about patient narratives and all aspects of the CAHPS program, is at www.ahrq.gov/CAHPS. We do have a brief evaluation survey that we would ask you to fill out at the very end. And with that, we're going to conclude again by thanking our panelists, Caren, Ingrid, Mark, Rick, all of you for participating. These are great questions. I also want to let you know that this team is very hard at work at writing up a lot of the sort of analyses that we kind of blew through today because of time limitations. But please be mindful of the literature, and that's one way to learn about it is through those email updates, because a lot of this is going to be reported soon in the published peer-reviewed literature. With that, I want to thank you all again for joining us and wish you a very pleasant rest of your day and week. Thank you.